if you want to do clipping or these kind of things, grasping the posterior leaflet with multiple scallops can be really difficult to grasp. So, and it was nicely shown in some nice 3D images by Becky Hahn, showing here a tricuspid valve, but here sometimes you only have 2 leaflets, and sometimes you have 4 or 5 leaflets. So really, to use your 3D to show this is really beneficial for this. We also have to keep in mind that there are additional structures of concern, because the AV node is really close to the septal leaflet, and also the bundle of His runs through the infraposterior margin of the membranous septum. So this is the region why this small region is left alone during surgery to avoid AV blocks or even total blocks. And this nicely illustrates when you come with your catheter close to the AV node and just press on it, you can have your AV conduction disorders already. So when you do transeptal or maneuvering around this area, you can see you can make this block. So be careful of this when you do interventions as well. So the causes are different than from the mitral field, because the causes of the tricuspid regurgitation are mainly secondary, because 75, maybe 80 or 90% is secondary tricuspid regurgitation. Only a small amount have a real primary lesion, so a lesion of the leaflets of the tricuspid valve. So normally you have left-sided problems that can lead to pulmonary hypertension. It leads to hypertrophy and dilatation of the tricuspid annulus and RV dysfunction, and this causes malfunction of the leaflets itself. And on the other hand, a small portion of these patients really have a leaflet problem, a leaflet abnormality, which can be congenital or due to rheumatic endocarditis or trauma. And when the disease progresses, you will see that normally the septal leaflets, which is attached to the septum, is spared. And the posterior region, which is attached to the inferior portion of the right ventricle, is spared because it's limited in its movement because of the diaphragm. But the anterior septal region is attached to the free wall and dilates over time. So what you will have is that this region, and especially in this direction, will dilate and dilate, because there's simply nothing against the heart that prevents dilatation in this direction. And for a good functioning tricuspid, all the components, like in the mitral, to function well. So it's not only about the tricuspid annulus, but the leaflets, the chordae, the ventricle, and the right atrium, which are crucial. And normally you have a lateral form of your tricuspid annulus, and which is not in a non-planar way, which the inferior portion is the highest point of the tricuspid annulus. But again, if you have dilatation into the introseptal or intraposterior region, expanding, you will see the tricuspid annulus gets more flat over time. And if you look at how to do for measurements on echo, it's important that the standard views, when we do a measurement according to the guidelines in a 4-chamber view, is actually frequently not the biggest plane, the biggest annular dimension. So if you look at from 3-dimensional imaging, and if we make a 4-chamber view and we cut, we can see we have a cut plane more or less like this, but we can see on the 3D image, actually the biggest diameter is more or less the red arrow. So if we align our 3D lines, we can get an image which is the same as the red line. You can see this is more like a short view where we can see the tricuspid annulus at its largest. So if we do measurements, I really recommend you to do it by 3D. It's important to get a base dimension because it's significantly related to outcomes, and even if the patient doesn't have tricuspid regurgitation now, the bigger the annulus is the bigger the chance they will have regurgitation over time. There's some nice paper, and I'm going to go into details about this now, about transthoracic imaging. Becky Hahn did some excellent work on this, showing different views where you can see the different leaflets. But for the sake of time, I'll move on to the TEE. And why is it so difficult for us as imagers to visualize the tricuspid with TEE? And this is also from Becky, but nicely shown because the leaflets are much thinner on the right side, and the annulus is actually a virtual structure. There is no annulus. And if we look at the anatomy and the location of the tricuspid, we really can see the tricuspid is the most anterior valve of you all. So the distance between the probe and the anterior located tricuspid is really large, so it's difficult to visualize this one. And also, there is no single plane or pathway in this esophagus that has a nice perpendicular view of the tricuspid annulus itself. So a lot of difficulties, a lot of problems to visualize the tricuspid annulus. So we have different views we can use, and we've shown this already. We have the upper, we have the mid, we have the transgastric, we have the transgastric. And for tricuspid, it's also important to keep in mind, we have deep esophageal views to show the tricuspid annulus. And I'm going to show you a more or less systematic way how to do this. So essentially, we show all the different commissures and different leaflets itself. So actually we do a full sweep around the tricuspid, showing the different coaptation points. And what is also really important in visualization that we use our biplane. Transgastric views are important as well, and we'll go over them shortly after this.
So again, different views showing the different leaflets. And of course, this is much more difficult to be compared to the microvolt, because now we have 3 or even 4 or 5 leaflets. So I will go around. For 3D acquisition, I think it's important view on your tricuspid, which has a nice, when the tricuspid valve is nice and centered.
And we have some additional structures that are in our field of view, like the SVC or the IVC, and I always try to get the aorta in, because that is a crucial landmark to align my 3D volume of the tricuspid. So normally we start with a bicaval view, which is more or less like this. So you have your IVC, SVC over here, IVC over here, we have your tricuspid. And if we rotate it, we use it more or less like this, because we put the aorta valve on top. So we have the septal leaflet, the anterior leaflet, and the smaller posterior leaflet over here. So nicely, always for your interventionist, try to visualize it and visualize your 3D at the same way, so they can get used to these images, because it's simply sometimes difficult for them as well. So how do we go around the tricuspid valve? So normally, to visualize the antral and septal commissure, we go around 0 degrees. And sometimes, especially also for clipping, we need to go minus 15, meaning that you go for 165 or 70. So a mirrored view to nicely show the antral septal commissure. If we move on to 50 to 60 degrees, we nicely have the septal and posterior region. And if we want to show the anterior and posterior, we go to 90 to 100 degrees view. So how do we start? So normally just by advancing the probe into the patient. So by advancing your probe, and you can nicely see it with the hardwork simulation software, if you advance, you start with a cut plane to the anterior and septal, and the more you push down, you can see you can go to anterior and posterior. Frequently, when the posterior leaflet comes in, you will see the coronary sinus appearing on your image. So just by pushing in, you can sort of systematically already show the anterior septal commissure. What you can also do is have a 4-chamber view and use antroflex and retroflex to show the commissures between antral septal. And if you do retroflex, again, the coronary sinus comes in. Frequently you have the anterior and the posterior leaflets being shown here. And also use a lot of biplane views. So put in the cut plane, so you make a perpendicular view to your 0 degrees, and then you have a short axis at the base, more or less, going a little bit higher, so with the anterior and posterior commissure. So at least more or less you know which leaflets you are looking at. Also, and again, I already stressed this, the deep esophageal view. So again, pushing the probe in more and more, the coronary sinus will appear. At least you have the anterior, and frequently you will see the going over from the septal to the posterior leaflet. Another trick is going to the 50 or 60 degrees, so trying to get an intercommissural view of your tricuspid, where we can nicely, frequently, sometimes when the septum is blurring your vision, just pushing the probe a little bit more deeper, and then you will have your septum more or less over here, and the shadowing of the septum will be in this area and not over your tricuspid valve. Just pass it in, and again, use your X-plane, because we now have your posterior, anterior, and your septal leaflet. So you can remember this by putting in your mind the pause, and just by moving your line from commissure to commissure, you know, because you know which leaflets are this, you know on the other side which perpendicular plane we are looking at. So between antral, septal, and just to show it again, so you move from the septal posterior tips, to septal anterior, and finally the septal anterior commissure. So again, by knowing the views and using your explain, you know better what leaflets you are looking at. And then we move on to the transgastric views, because we can do a lot of stuff in the esophagus, but frequently it's quite difficult to know for sure which leaflets we are looking at. And during the procedure, an easy trick to do as well is to find your short axis at the axis view of your tricuspid. Frequently it's not that nice as a mitral short axis view, but we have the anterior, the septal, and the posterior leaflet. And then now the nice thing is what we can do. Again, use our explain line, because we know which leaflets we are looking at. And if we move our explain line up and down, we know in the perpendicular view which leaflets we are looking at. Like here, we have the anterior, and this is posterior and septal commissure. And if we move along, we can move along to the anterior and posterior. So again, using the information you know to create the images, sometimes it's difficult to understand which leaflets you are looking at. Also here, you can use your anteroflex and retroflex, but again, it's sometimes more difficult to understand which leaflets you are looking at. So retroflex, you will create a view with the posterior and the anterior leaflet, and the other way around with the septal and the posterior leaflet. So again, also possible, but sometimes a little bit more insecure looking at the leaflets. What's also important when we're going to do evaluation of our patients before we do an intervention, like when we move to a cardio band or a tri-stitch procedure, when we want to insert several anchors in the annulus of the tricuspid annulus, you have to keep in mind that the coronary artery, the right coronary artery, is really close to the leaflets and the leaflets itself, and especially on the posterior side, it's really close to the leaflets itself. So you have to make sure before you're going to insert these anchors that the distance is enough and you're not going to injure the right coronary artery. And then finally, moving on, before I'm over time already, quantifying the tricuspid regurgitation, that's definitely a difficult issue. We already have difficulties on the mitral side. There have been extended schemes, nicely made again by Becky Hahn, helping us to quantify the tricuspid regurgitation. But what we see, because the free wall can expand that much and the leaflets of the septal frequently get restricted more and more, we do not only have a severe mitral valve regurgitation, but what they would like to do is a more extended classification, so moving on from severe to massive and even torrential tricuspid regurgitation in these patients, because they simply can have very large gaps in between these leaflets. And what they saw is that if they even did interventions and they were significantly reducing the tricuspid regurgitation, the patient still went from severe to severe. So to help them a little bit, now at least you go from massive to severe and show that you did something well for the patient. So if we want to quantify, we have to keep in mind there are three components of the regurgitated jet. So we know that the pisa, the vena contracta, the smallest part, and the jet area. But if we use the vena contracta, and it was already a problem on the mitral side, you can see that the vena contracta area actually is not a single plane measurement, because if you measure here, or you measure here, or you measure this, you will have complete different measurements, and sometimes you have this more star-shaped kind of regurgitation area, so it's really difficult to do. What you can do as well is to use the PISA method. So you visualize the PISA, and if you have a PISA radius above 9 millimeters, it's been associated with a presence of a significant TR. And you can see in all these grading schedules, the problem is that they all rely on PISA, and the PISA has several limitations. So if you look at the PISA, it assumes that the area where you do the measurement, the surface is flat, but the leaflets are frequently completely tethered into the LV, so that doesn't work out. It assumes that it is a circular orifice, but like I already showed, it's frequently not circular. It's semi-lunar, or it's a star-shaped orifice. it assumes that it's a hemispherical piezo, but also, again, it's frequently not hemispherical, there's one, and it measures the piezo in just one single time shot, and you know it's a dynamical phenomenon that we see in the mitral valve regurgitation as well, and also inspiration and expiration is really changing the amount of tricuspid regurgitation looking at the piezo. So finally, what I would recommend, if you have 3D capabilities, to go for 3D vena contractor area, just cutting into your 3D box, nicely showing the star-shaped vena contractor area, and do your measurements here, because it nicely has been shown that it, I'm going to skip this for the sake of time. Here we go. Yeah, I will stop, because I just want to show one image. Doesn't want, somehow, doesn't want to continue. Somehow it doesn't want to continue to my last slide. Maybe with this, let's see. Somehow it completely stopped. But what I wanted to end up, it's not only about showing the tricuspid regurgitation itself, but also look at the consequences. So do your RV dimension, do your right atrium dimension assessment as well. And look at the newer methods, so like RV lateral wall strain, or maybe this new Thumbtack software where they can have nice 3D volumes of the right ventricle itself to help you out to quantify the significance of the TR. Thank you very much.